In this peptic ulcer disease, they can be used for both NSAID induced and H. pylori induced ulcers. The third one is stress ulcers. The fourth one is just a hyperacidity. And the fifth use is urticaria. Urticaria is kind of an allergic condition which is mediated by histamine, so H2 blockers can be used in its treatment. The sixth is prophylaxis of aspiration pneumonia. As a pre-anesthetic medication. But for all these, except urticaria, for all these conditions, now PPIs are more commonly used and they have become the drug of choice. So what is meant by this prophylaxis of aspiration pneumonia as a pre-anesthetic medication? Before surgery, a patient is anesthetized, and during surgery, and the protective laryngeal reflexes are lost. So the stomach contents can be aspirated into the lungs, and this can lead to chemical pneumonitis and aspiration pneumonia. So if we use H2 blockers or proton pump inhibitors, there is reduced acid production, and this can decrease the chances of aspiration pneumonia. So they are used for prophylaxis of prevention of aspiration pneumonia. You can call it prevention of aspiration pneumonia. So what are the side effects of H2 blockers? Most side effects are non-specific, such as headache, abdominal pain, loose stools, myalgia. Now, acid is also responsible for absorption of certain nutrients such as calcium, iron, B12 and magnesium. So deficiency of these can occur. Calcium deficiency can lead to osteoporosis and can increase risk of factors. Iron deficiency can lead to anemia. B12 deficiency can occur. Magnesium deficiency can lead to hypomagnesemia and can also cause secondary hypocalcemia. So these deficiencies can occur. Now the next category of drug is proton pump inhibitors. Proton pump inhibitors are prodrugs. They are benzimidazoles chemically. They are weak lipophilic bases. They have a pKa of around 4 to 5. So pantoprazole has the lowest pKa of 3.9. Rabeprazole has a pKa of 5. And rest all have a pKa of 4. pKa is that pH at which the drug is 50% ionized and 50% non-ionized. Now, proton pump inhibitors are acid labile drugs. They are destroyed by acidic pH of stomach. So they come in an enteric coating. There is an enteric coating over the tablet or capsule to prevent its disintegration in stomach, and it is absorbed in intestine as the prodrug. Now when it enters the parietal cell, in the acidic medium of parietal cell, this prodrug is converted into its active moiety, that is sulfonamide cation. And this sulfonamide cation inhibits the H plus K plus ATPase pump. And this pump is inhibited by proton pump inhibitors in an irreversible fashion. So the serum half-life of proton pump inhibitors is 2 to 3 hours, but their action remains up to 18 hours because synthesis of new pumps requires up to 18 hours. So they act for almost a day and they are given as once daily dosing. For few indications, they may be given as twice daily dosing also. But even their once daily dosing is sufficient. If we give continuous administration of proton pump inhibitors, then the pumps are from the last dose, the pumps are suppressed for up to 2 to 5 days. On the other hand, H2 blockers, their half-life is around 6 to 10 hours. And they should be given as twice daily dosing. Now, absorption of proton pump inhibitors is also interfered by food. There is interference by food. So, proton pump inhibitor should be taken empty stomach. But in fasting state, only 10% of pumps are active. So patient is advised to take proton pump inhibitors 30 minutes before breakfast. Now when patient takes a meal, the proton pumps become active and the peak serum concentration coincides with peak H plus K plus ATPase pump activity. Now omeprazole and esomeprazole are inhibitor of CYP2C19, and these have drug interactions. Now one significant drug interaction is with clopidogrel. Clopidogrel is a prodrug and its conversion into its active forms requires CYP2C19. But if a patient is given omeprazole concomitantly, then omeprazole inhibits this CYP2C19. When CYP2C19 is inhibited, clopidogrel cannot be converted to its active form, and thus there is failure of clopidogrel therapy, and it can increase the risk of stroke and heart attack. Clopidogrel is usually given with aspirin as dual antiplatelet therapy for prevention of heart attack and stroke. So if Omeprazole or esomeprazole is given concomitantly with clopidogrel. Then there is increased risk of heart attack and stroke. Now, two proton pump inhibitors. Pantoprazole has minimum drug interactions. And rabeprazole has the second minimum drug interaction. So these drugs can be given with clopidogrel if needed. Pantoprazole is not an enzyme inhibitor. And the next one is rabeprazole, which is safe in this regard. Rabeprazole also has fastest onset of action. It is very fast acting. Pantoprazole is a long acting drug. Now, what can be the adverse effects of proton pump inhibitors? First, there can be non-specific adverse effects such as headache, myalgia, abdominal pain, loose stools, etc. Second, there is increased risk of acute interstitial nephritis. And chronic kidney disease. On prolonged use. So prolonged use of proton pump inhibitors should be avoided. Thirdly, acid is required for absorption of certain nutrients such as calcium, iron, B12 and magnesium. So deficiencies of these nutrients can occur. Deficiency of calcium can lead to osteoporosis and can cause increased risk of fractures. Deficiency of iron can lead to anemia. Acid is required for conversion of ferric iron to ferrous form, which can be absorbed. Vitamin B12 is extracted from dietary foods through acid, so vitamin B12 absorption also decreases. Magnesium absorption also decreases, which can lead to hypomagnesemia and secondary hypocalcemia. These deficiencies are mostly seen with long-term use. Then acid is also responsible for maintaining integrity and maintaining the anti-infective property of mucosa. So anti-infective property of mucosa is given by the acid, and proton pump inhibitors can lead to increased risk of community acquired pneumonia and hospital acquired pneumonia. So there is increased risk of pneumonia. There is increased risk of spontaneous bacterial peritonitis. There is also increased risk of Clostridium difficile infections, and it can lead to pseudomembranous colitis. It can also lead to hypergastrinemia. Now, this hypergastrinemia can lead to increased acid production after stopping the PPI. So, for few days after stopping PPI,